Hello, and welcome to Conversations with Dr. Kohli. I'm your host, Dr. Payal Kohli, Associate Adjunct Professor in the Cardiology Division at Duke University and non-invasive and preventive cardiologist, founder and medical director of Cherry Creek Heart. And today, I'm delighted to be joined by my colleague, Viet, who is an Associate Professor of Research and a Preventive Cardiology PA at the Intermountain Heart and Vascular Center, and he's also the past president of the Utah Academy of PAs. Welcome, Viet.
Hey, thank you. I appreciate the opportunity.
I'm so excited to have you here because you're really somebody who practices medicine at the bedside. And today I want to pick your brain and I want to learn everything that you know about icosapent. Now, this is a drug that some of us may not be familiar with, but if you remember the Reduce-IT trial, which was a trial of patients who were a secondary prevention, so they've already had, cardiovascular event, or high-risk primary prevention, meaning diabetics with other risk factors, and their triglycerides were moderately elevated in the 150 to 499 range, they actually had a 25% risk reduction with the use of this medication. And if you looked at the total events, it was a 32% risk reduction. So my first question for you, as preventive cardiologists, we have so many tools in our toolbox. We often think about LDL-C as the bad cholesterol. That's the one we want to get down first. When do you start thinking about this type of a medicine, icosapent? Do you first work on LDL? Do you do it in a parallel fashion? Or do you wait and assess the patient's risk and then decide whether or not to use it?
Yeah, I mean, these are great questions. And if you haven't heard of icosapent, then honestly, go back to the Reduce-IT trial. It's fantastic. Here, it really has to be done concurrently. They're different therapies. They're different targets that icosapent and any LDL cholesterol lowering therapies do. So here, the trialists were that designed the study did such a great job in looking at secondary prevention. So, ASCVD, of course, you should be looking at implementing icosapent in that population, really kind of regardless of the LDL cholesterol, but we do have to follow the FDA indications here. Same with diabetes and risk factors. I just think about it early and often, because it does do different things. But having said that, with the FDA indication of when to use this, really, of course, the guidelines tell us to first manage LDL cholesterol and get it within range. Here, the FDA has allowed for maximally tolerated statin, and then really left over is the triglycerides that are greater than 150 milligrams per deciliter. So yeah, I think about it early and often in all of my patients, because it's really not a traditional lipid lowering therapy, right? Here we're actually use triglycerides as an excuse to implement a therapy that has multiple pleiotropic mechanisms.
What I really like about what you said is that it really is a parallel pathway. And what I do in my patients is I kind of wait to see the LDL finish line. And the reason is because statins, as you mentioned, are kind of the workhorse of LDL lowering. They can also lower our triglycerides. So I don't want to pull the trigger prematurely, but when I'm getting close on the LDL, if those trigs are still elevated over 150, then you don't want to delay too much. And the expert consensus decision pathway suggests around 100. For your LDL. So when your LDL is below 100, it's time. You're not quite at the finish line yet. Most of our patients, we want to get to 55, but you certainly want to start thinking about those triglycerides. Okay, so let's say we've made the decision to start icosapent. How do I start it? Is it once a day? Is it twice a day? Do I need to worry about kidney function, about liver function? Is it the same dose for every patient? What do I do there?
Yeah, here I think it's very simple, because it's really a daily dose that we want to achieve, and that's 4 grams. But the dosing, the capsules themselves don't lend easily to that necessarily. So typically it's a 1 gram capsule that you're taking 2 tabs, and then twice a day. So 4 total capsules. And I cheat a little bit here. I do have folks, because some have a sensitivity, GI sensitivity to icosapent. Typically, I write it as is, and then have them start really kind of once in the morning with food. It should be taken with food or immediately afterwards. Kind of test the water a little bit for a couple of days, and then go to twice a day with 1 capsule. And then ultimately, they should be on 4 grams total. So 2 capsules twice a day.
Okay, I like that. I think kind of getting you into the swimming pool one toe at a time, really, really nice strategy. So you mentioned a little bit about GI sensitivity. Talk me through what you tell your patients about the side effect profile, what they ought to worry about, and what I ought to worry about as a provider who's starting this. Are the things that I need to watch out for?
Yeah, here we have some great information across the different omega-3 trials, and that's with whether they're mixed or not. And what I'm alluding to is a common, folks point to atrial fibrillation as one of the kind of the side effects that can happen. But if we remember what the true reason why we're starting icosapent ethyl, it's cardiovascular mortality, it's cardiovascular events. And AFib is one of those things that is manageable. I'm not being cavalier here, but at the same time, the event rate wasn't very high. I mean, we're talking about 3% versus 2% in a placebo-controlled population. The fact is anyone that's high risk for cardiovascular disease is risky also to develop atrial fibrillation. So from a side effect profile in terms of GI and other things, we have to remember that EPA or icosapent ethyl does have a mechanism for which it can lead to bleeding, increased bleeding. And so that's something to watch for. In particular, with our ASCVD patients, often they are on antiplatelet or antithrombolytic therapy. So just be careful of that. I mean, you can monitor that by questioning, of course, for any bleeding. But you're also most likely doing a CBC from time to time, and you can look for any occult bleeding. So bleeding is one of those things I'd watch for. GI side effects are not uncommon, I think, with any pills. But when you're taking 2 pills twice a day, yeah, I mean, those are things that can happen. I was one of the trialists for the Evaporate trial, which is, the sister mechanism trial. And one of the things that seemed to help for patients was to actually freeze the medication overnight and then take it as frozen. And so that actually eased some of the side effects for the GI side.
Oh, interesting. Yeah.
It was really interesting. And even now you'd say, well, does it mess with the mechanism? I can't tell you in the trials what they show, but I actually follow my patients with an EPA level. And I haven't seen a difference in the achieved EPA. Typically, you get anywhere from 140 to 160 micrograms per deciliter. So I think I do follow my patients with an EPA level, but at least it's tolerable. It's something that's more tolerable. So from the GI side, those are some of my kind of tips. Remember bleeding. That is something to think about. And then the atrial fibrillation side of things is it happens in cardiovascular disease. But here I don't want to be cavalier about it, but it's not enough for me to stop something that reduces events, 25% relative risk reduction. And that includes death.
It's interesting. I had a patient who I was sure he had AFib. He would come in with palpitations. He had sleep apnea, hypertension, diabetes, obesity, every possible risk factor. And I never caught it on a monitor. It was always atrial tachycardia. And I started icosapent ethyl. And he showed up in the ER with AFib. And in a way, I was relieved because I was sure he was having occult AFib. So to your point, yes, it can unmask that AFib. It can even sort of increase your risk a little bit, but that treatment difference is pretty small. And at the end of the day, we worry about strokes with AFib. And this, we know, reduces your risk of ischemic stroke. So certainly watch out for AFib, for bleeding, for GI side effects. Talk to me about the labs. You mentioned a little bit the CBC you might check. EPA is generally not recommended by the FDA, but certainly an interesting lab to check because we know that the bioavailability of the medicine differs between person to person, and also where your EPA starts and where it ends up can also differ. Do you check any other labs when you're starting this on a patient?
Yeah, I mean, I think again, coming back to its indication, triglycerides. So I do check a baseline lipid. Certainly, that's what prompts you to utilize icosapent ethyl. But I do follow it again, very similar to for me, the mechanism is such that you can see the difference within 3 to 5 weeks. In guidelines for lipids, you can, it's 4 to 6 weeks. And when you're seeing a difference that early, I think it's helpful to a patient to get the information quicker. They're more likely to remember what you said at the time that you started these therapies. And you're not so far off or too early rather that, you're not at nadir. So what I'm saying is that doing it as early as 3 weeks is helpful because you can still see the effect on the triglycerides. CMP is, I don't think there's really an interaction with the liver. But from an FDA standpoint, they do ask that you follow ALT, AST, so transaminases. What you do with that ultimately, I don't know that it changes what I would recommend in a patient in terms of ongoing icosapent ethyl. The mechanism is not there, but it was something that was followed in the trials. So CMP, CBC for bleeding, and then of course lipids, because you want to see the effect. Spoiler alert, I don't think that it's triglyceride driven, but at the same time, it does reduce triglycerides by up to 30%. So you should follow what you're trying to ostensibly treat.
Yeah, that's a good point, because in the Reduce-It trial, it didn't matter where your triglycerides got to, you had the same risk reduction. So clearly something pleiotropic going on here. All right, let me ask you about shellfish, right? I mean, icosapent ethyl is derived from fish oils, EPA, which is a fish oil. It's a purified ethyl ester of that particular fish oil. So what about a patient who has a shellfish allergy? Have you had any patients like that? Have you used those types of patients?
Yeah, so, it's funny because it's more reported by people than I think is actually real. Perhaps I think folks kind of think they have some type of fish allergy, but in this case, it's not necessarily the same. So, like you said, it's derived and it's chemically derived icosapent ethyl, and it's not the same as giving someone truly a fish oil like you would see in shellfish. So there's no recommendation to not utilize icosapent ethyl in people who have a known or proven shellfish allergy. I think the main thing here is it's an interesting way that they said it because it's true, is if you have a hypersensitivity to icosapent ethyl, not that you have a shellfish allergy, then probably not use icosapent ethyl. How would you know unless you used it? But here, I don't think that there's any problems with someone that has a proven allergy to shellfish. You're okay using icosapent.
So I would just carefully monitor those people. Yeah. I think I've used it in one patient who told me that she thought she had a shellfish allergy, and I didn't challenge her with real shellfish to see whether or not it was a real allergy or perceived. But okay, well, that's good to know. All right. So you talked a little bit about bleeding, and it has an antiplatelet effect, so it can increase your risk for bleeding. Do you do anything around the time of surgery? Do you interrupt the medicine if somebody's had a bleed? How do you sort of treat patients who might have had either minor bleeding, like a nosebleed, or somebody who might be having a surgery or potentially had a major bleed?
Yeah, I mean, it's interesting. It is part of its mechanism, this pleiotropic effect. And so you wonder if that leads to partly the reduction in stroke risk in the primary and secondary outcomes of the Reduce-It trial anyways. I don't really make any recommendations to stop or reduce or hold icosapent ethyl. I mean, even if you look at the trial, the bleeding risk, yeah, there was a difference, but you couldn't point to any one of the, acute or any of the treatment emergent adverse effects to like, oh yeah, this is why I would stop it. I don't know that would be something I would recommend. I think it's okay to use icosapent ethyl through surgery. I think the main thing is the antithrombolytic. You're going to manage the antiplatelet and the anticoagulant. I'm not sure that it's enough of a signal, or that the mechanism is so causal, I think, at least clinically significant, that you would change your icosapent ethyl dosing. It is something to be aware of, maybe put it in the chart, but I don't know that it moves me to, and it hasn't, by the way, it hasn't moved me to make any recommendations to stop it or hold it.
Thankfully, I've been lucky that I haven't had any significant bleeds for patients that are on IPE. I presume if somebody had a major GI bleed, got an intensive care unit, that may be a medicine that I would think about stopping. But to your point, I feel like for surgery, elective surgery and such, it really hasn't come up in the literature. It hasn't seemed to be creating any kind of clinical signal. So that's helpful. Okay, last question before I let you go. And this is hot off the presses because there was just a trial today about fish oils. Yes. You have your patients come in, they want to take the fish oil. 20 to 30% of Americans take or have taken a fish oil at some point. What do you tell your patients? Because, guess what? IPE reduces cardiovascular events. So maybe fish oil, which is, IPE's parent, also reduces cardiovascular events.
Yeah, no, this is such a great question. I had a patient today. I have
Oh,
my
today.
yes, and they were on krill oil. Um, this is the thing. I mean, there are so many regulations when it comes to a therapeutic agent, especially when it's FDA, approved. And so, from a prescription standpoint, all of these things are monitored. You have to have a good manufacturing processes. The problem within the states, I don't know that I could speak for international, but I assume there's some similarities in the states. Please, be careful. Don't call these over the counter. They're not. That's an FDA regulation. That's a prescription drug that is now over the counter from the pharmacist. You can get it off the shelf now, but it's still OTC. Nutraceuticals are off the shelf. They are regulated differently. Actually, there's very little regulation other than if they claim something, then the FDA gets on them. But we don't know what's in the krill oil. I have no idea what's in that omega-3 whatsoever from, whatever nutraceutical company, because it's not regulated. And so it could be rancid. It could be less than 20% of what's purported on label. And furthermore, when you think about all of the off-the-shelf nutraceuticals, they're a mixed variety of EPA and DHA. And we saw that in the strength trial. I mean, that's prescription based medication that was EPA and DHA at high levels. And we knew what was in it. It came out neutral. All the studies that show benefit are EPA alone. And so first, I would say they're non-regulated. We don't know what's in off-the-shelf nutraceuticals. But the second part is they all purport to have EPA and DHA, which we have not shown in any clinical trial is beneficial. So I tell patients, look, first of all, understand why you're taking it and what it's for. If you're doing it for cardiovascular, I can tell you that EPA, DHA combined isn't helpful. We haven't seen it. And then the second part is, we don't know you're taking. I don't know what it's cut with. It could be any oil inside there. And so we're just guessing.
Well, I totally agree with everything you said. And I say the same to my patients, save that money and don't pay the price, because you're paying the price not just with your dollars, but also of atrial fibrillation and increased risk of bleeding.
So I want to thank you so much for all your insights, for taking us through how to use this medication at the bedside, and for sharing your tips and tricks with us. Thank you so much for joining me today. And to our audience, thank you so much for joining us. And we'll see you on the next episode of Conversations with Dr. Kohli. Take care.
Thank you.